There you go.
All right. Ready for us to start? Okay. All right, so we'll go ahead and get started. My name is Diane and this is Karen, and we're here to talk about Millennium Therapy Services here at Oak Knoll. Our company is actually contracted in by Oak Knoll. We have an office over, I don't know what you call it, in the main building on the other side of town. So we thought we'd just kind of go through what kinds of things we treat, and then at the end kind of tell you if you need to see us, what you need to do to be able to come see us. So I'm going to go ahead and start since I have the microphone, and I will tell you that I get a little nervous speaking to large groups, but I'll try not to talk too fast. So
We're totally sympathetic.
okay. Thanks. So my name is Diane Vogel, and I am the physical therapist. My background is I attended Cornell College in Mount Vernon for my undergrad, and then I came to Iowa for my master's degree twice. So I actually have my master's degree in sports, health, leisure, physical studies with an emphasis in therapeutic rec. And I went back for my second master's in physical therapy. So, and I've been working at Oak Knoll now for 11 years. So I'm going to let Karen introduce herself.
My name is Karen Randall. I'm a Smallie. I grew up on the south side of town. Diane always gives me a hard time. I feel like I have connections with a lot of patients that come our way. So I went to West High and Wartburg College, and then got my OT degree at Eastern Michigan. So went out of state for a little while, and I've done a lot of different age ranges of therapy, worked for about 10 years with children, and then worked in an acute care setting, and now I've been at Oak Knoll for about 7 years. So we live now a little west of Solon. So at Oak Knoll, it's been nice to get to know or reintroduce myself to some of my classmates' parents, and so that's been fun. You want to go to the next part?
Yeah. So we also have speech therapy services, and we just had a new speech therapist come on board with us. Her name is Amber Crawl. She couldn't be here today, but she's looking forward to meeting and working with the Oak Knoll residents. So we're going to start with speech therapy services. Karen's going to kind of tell you a little bit about the services that they provide, because contrary to popular belief, speech therapy is not just about speaking. So Karen's going to go through some of the different problems that you might need speech therapy for.
Okay, so if all of you are here, you have been able to swallow your pills, been able to take a drink of water, been able to talk on the phone probably, or read what's on the bulletin boards there to get you here. All of those things are dealt with by speech. So speech in the truest sense of the form can be about pronunciation. It's about verbal communication, being able to express yourself in different ways, and even to the point of augmented communication, which can be like a communication board or a computer device that speaks for you. So as far as speech goes in that way, it's both receptive and expressive, both how you hear language. It can be helping your caregivers learn how to talk to you so that you can best understand them. And the expressive part, being able to pronounce, like I said, or find alternative ways to speak. Speech also, because it's, I think, in the throat and mouth area, also deals with a lot of dysphagia, difficulty swallowing. It can be liquids, it can be solids, it can be pills. They help people with, maybe someone's had a stroke and has one side that's a little bit weaker than the other. They're at risk for choking, and so there may be a diet modification that they would make to help. If you can think about swallowing liquids, if you've ever choked on a swallow of liquid, a thicker liquid is a little easier to control for some people that have swallowing problems. Maybe there's a different way to take your pills, or a different consistency, liquid versus solids, or crushed versus whole pills. That kind of thing a speech therapist works with. They are also our specialists in cognition. So they may do some testing to determine if there is a memory deficit. So they have a number of different standardized tests that they can measure memory and understanding with, and also help with some compensation, some strategies in memory, and so those are the kinds of things. Do you want to stop in between for questions? Or?
Yeah.
Okay. So, any questions about speech therapy? Yes.
My question is more.
She's going to bring you a microphone.
My question is more organizational for you guys. I take it that Amber also works for Millennium.
Mm-hmm.
Yes.
And do you work exclusively with Oakland patients, or do you see other patients as well?
We see other patients as well. So it's, we are contracted with other nursing facilities, other rehab facilities. We go to different outpatient and home health agencies. So we don't usually work with someone from the community coming into Oak Knoll. They generally have to have an Oak Knoll connection to work through our Oak Knoll clinic. So,
Interesting.
yeah.
Okay.
So organization-wise, there's a couple, so speech may look at how an individual would organize their bills or their finances, some things like that, some strategies that way. OT, or what I do, occupational therapy, maybe more of a physical organization, a sequencing kind of thing. So.
But we contact you through Oak Knoll and you have offices at Oak Knoll?
Oak Knoll, right,
Okay.
right. Okay.
And we all do just a little bit, have a little bit different responsibilities. Like I pretty much always see Oak Knoll residents just because of how busy we are with physical therapy. Speech therapy tends to come to Oak Knoll as well as go to some other locations because they just don't have as many people to see here, so they have more time to go other places. But so we all have kind of a little bit different schedule, but as far as going other places.
That answer your question?
Yeah.
Okay.
Any other speech therapy or other questions?
My wife Barbara had a stroke in 2017, had a lot of speech therapy through nursing. And yet she was interested in coming here today and for us to be able to evaluate what you can do to see if there's a fit there. And I guess my only quick question is, what would be my next step? Do I call, and whom do I call?
Yeah. So a couple of things related to that, and you can jump in if you have something else to add. If you know that you want to get speech therapy orders to be evaluated, I'm going to talk about that at the end, kind of how you get the orders and go about coming to see us. So I'll save your question for later. If you have a question about whether or not she's appropriate, we can always ask the speech therapist. You can kind of tell her what your concerns are or problems are, and she can tell you whether she thinks she can help you or not. So, yeah. Any other questions? All right. Well then, back to physical therapy. I do also work with a physical therapist assistant. His name is Matt Wilson. So if you get physical therapy services, you may see either myself or Matt. And we generally work on lower body, back and neck pain, and mobility issues kind of in general. You have the list kind of in front of you that talks about some of the different things that we do. So decreased strength, generally in the lower body, because if you're having trouble with your upper body and arms, that tends to go more occupational therapy because of how it relates to your dressing and what we call ADLs, and Karen will talk a little bit more about that. But decreased strength, decreased balance, which can contribute to falls, decreased activity tolerance or endurance, just kind of working on general strengthening. All of those things can lead to falls too. So we also can help you decide what assistive device is right for you, and by that I mean like a walker or a cane or nothing. You know, if you work with us, we may or may not be able to help you improve to the point where if you are feeling a little unsteady, you feel more stable once you've done some balance work. If you don't, or if you need something in the interim, we can help you decide if a cane's enough, what type of cane. If you need a walker, there's a lot of different walkers out there on the market, I feel like today. The kind with no wheels, the kind with 2 wheels, kinds with 4 wheels with the seat and brakes, and then the newest one that you see a lot is the stand-up walkers, where people, it has armrests up here. I'm seeing more of those around Oak Knoll on the other side of town and just in general. So we can kind of help you discern out which might be best for you if you're not sure. So also pain, we see a lot of different issues with pain, whether it's knee pain, hip pain, back pain, neck pain. We work on all of those things with people. Trouble getting in and out of bed, up and down from chairs, in and out of a car, all of those things usually are related to strengthening, why you start having trouble with those, and a lot of times just focusing on maybe some specific areas of weakness or technique. Sometimes it's not so much weakness, sometimes it's technique, how you're getting out of a chair that can make a big difference in being able to get up and down. So we can help you, to know whether you can do something better to be able to get in and out of bed or up and down from a chair, and also if it just takes a little bit of strengthening. So we do have some different techniques that we use. I mentioned the strengthening. We also have some what we call modalities, which the primary things that we use are electrical stimulation and ultrasound, and typically we use those for pain. It kind of depends on where your pain is, how big of an area it is. Ultrasound oftentimes works well for a small area of pain that's musculoskeletal related. If it's a more diffuse area, sometimes we can use electrical stim because that covers a larger area. There are some precautions for those that usually I'll go through with you. If you have active cancer, it's a precaution not to use the ultrasound. We can't use electrical stim with a pacemaker, so there's some limitations to being able to use those with people, but those are some things we can do to you to try to help with the pain. Most of the other things we do involve you doing the work, like the exercises for strengthening, a range of motion sometimes. Whether it's arthritis related, whether you've injured yourself, you can have limitations. You can only bend your knee this far. And you need to be able to bend it more than that to walk and get in and out of the car and do things a little more efficiently, so we can help you work on range of motion. Sometimes we do manual therapy. That I guess we tend to do to you like we do the ultrasound and electrical stim, where we may find muscle tightness and we'll kind of massage in that specific area to help work out if there's muscle knots or soreness, to help decrease pain. We also, like I mentioned before, help you with the walking, whether it's to decide on a device or help improve your walking pattern. So balance, we do a lot of balance too. We have some balance tests that test a lot of different areas of your balance, so it can kind of help us define when are you most likely to lose your balance. What should we work specifically on? Do you tend to lose your balance when you're turning, or is it when you're walking, you're not picking up your feet? We can see if you're shuffling and work on some of those things. So, and the balance tests are usually helpful because insurance loves numbers. So balance tests gives us some numbers, and it also helps both of us see if you're improving or not. Usually the tests will indicate if the tests show you're indicating, most of the time people can tell that they have shown some improvement to go along with that. So I do think they're pretty accurate. So, and then I also do have some special training in Parkinson's to work on just general mobility and decreasing fall risk and whatnot. So, any questions on physical therapy before we move on to occupational therapy? Yeah. So Mark's question was, have we worked with people with primary lateral sclerosis, which is kind of like mobility kinds of things, a lot of sometimes adaptations, and a lot of times OT is better at the home safety adaptations, and Karen will talk a little bit about that too, but if something needs changed in your environment, like an elevated chair or a grab bar, bed canes, things like that. Sometimes I do a little bit of that, especially if it's bed mobility related, but Karen focuses a little bit more on that. But so yeah, and you know, there's a lot of different diagnoses out there, and we kind of just take into account what your limitations are along with your diagnoses and what things we might see, especially if it's something progressive, which primary lateral sclerosis is. So we're kind of anticipating what might be coming up sometimes too. So did I answer your question? Yeah.
What about, do you guys want to evaluate us as new residents of Nome now, or do we wait until we have a crisis?
So we typically, just like if you were going to go to an outpatient clinic, we do an evaluation when you come to see us. We don't typically do an assessment or evaluation to begin with. So
Yeah. That's a little different if you were to come to assisted living.
yeah, I'll let you tell them about that.
So if a resident was to transition to assisted living, that's a little different level of, or it's a lot different level of care. We usually do get a doctor's order to evaluate residents when they first come, or when they're first admitted to assisted living or the health center. And a lot of that is to determine their level of care, how much assistance is needed, how much caregiver education on whether a resident would need help with a shower or medication management, that kind of thing. You guys are coming in here independent, so we're assuming you're good to go unless you have a problem. When there's a resident that goes to a different level of care, that's kind of a multi-level change for them. So then that we do a admission assessment, basically. Yeah. Mm-hmm. Yeah. Let me go ahead with talking about. Oh yes.
You mentioned insurance. I wondered about the coverages that the therapies might have from Medicare and Medicare supplement, and how we go about getting it.
So I'm going to save your question for the end too, to go along with how to get the order, because I'm going to talk about both of those things at the same time, if that's okay. Okay. Any other physical therapy questions before we move on to occupational?
Okay, so has anyone here had OT before? Did you have OT after your stroke? No? Okay. I feel like I've spent most of my life describing what I do. Even my parents struggled with that when I went out of state to school. But occupational therapy, your occupation is taking care of yourself. And so it's daily living skills, getting dressed, going to the bathroom, taking a shower. It's independent living skills like cooking, laundry, cleaning, those kinds of things. So if you can imagine having hip surgery, any of you had a total hip replacement? Okay, one potential client, no. What hip replacements have restrictions because of the dynamics of the implant. Patients are not allowed to bend. So this is a 90-degree angle. They aren't allowed to bend past that to reach their feet. They can't cross their legs, and they can't twist. And so there's a lot of things you can't do. You can't reach your feet. You can't tie your shoes. Maybe your shower is different. So for your occupation, we have to make some adjustments. And it can be through adaptive equipment. It can be through the position that you do things at. It can be teaching your caregiver how to assist with those things. So activities of daily living is a big part of what I do, especially if there's been a significant change like a stroke or orthopedic surgery that way. Independent living skills are things like, things that I might do with a patient is, you know, there's 1,000 different types of microwaves. And you probably noticed that when you moved into your apartment. This wasn't like your one at home. And so it can be working through with the resident to determine, you know, what's the most important things. I have a resident in assisted living where we just put tape over half the buttons and only have the numbers there, you know, because you go there and maybe the lighting isn't as good, maybe we increase lighting, maybe we highlight some things, people with low vision, to try and make their life as simple, as independent and successful as they can, where you're at right now. There's a lot of things that get harder as we get older. I don't have to tell you that, I know that too. And so there may be a way to adapt to that. Maybe reaching into the dryer is getting harder. We could raise the dryer up, put it on a riser. We could give you a device to grab things out of the dryer. We could teach you a different method, maybe sitting to reach things. So it's breaking down each task and trying to find what the problem is, how you can be more successful with that, with activities of daily living and independent living skills. So as part of that, as Diane said, part of the problem you might have that causes you some limitation is a problem with your hand, a problem with your wrist, shoulder. So in some clinics, physical therapy deals with shoulder pain. In our clinic, I've taken more, a little more continuing ed, and that's kind of my area at Old Knoll. And so arthritic shoulders, am I buzzing? Shoulder injury of some kind. I may use some of the modalities, ultrasound or e-stim, like physical therapy does. I can do positioning of hands. Sometimes there's a joint deformity that occurs with arthritis, and there might be a splint or a brace that we could come up with to make that more comfortable. So as far as arm and hand, there might be exercises you could do to make your hand or shoulder stronger. Maybe there's a way to enlarge the grip of something. Someone that crochets a lot, I've used built-up handles on the crochet hook so that they didn't have that hand spasm. You know, it's little things that you take for granted. And if you're struggling with it, maybe there's something I've done before, or maybe we can work together to come up with ideas. I learned a lot from patients and residents on what they've tried. And the other area that is in my department is with wheelchairs. So if you have a need for a wheelchair, I can help with determining maybe whether you need a manual wheelchair. That's one that somebody else pushes, or you can learn to push on your own. Or we have some renegade patients and residents that order their own. And then we have to figure out how to make it work, Mark. So, and that's okay too, you know. I've learned a lot about your wheelchair, and I had never dealt with that type before. So you went ahead and got it, and then we taught you how to use it, right? Yeah. So, and there's a lot of different styles of wheelchairs. If you have been through a walkthrough at Oak Knoll, you'll see a lot of different types. We have one gentleman that's still in his independent living apartment that has a $12,000 wheelchair that lifts him up, tilts him back, whole chair moves up, and so, you know, it's different things, and he can make that work. So, we don't do the fitting of the wheelchairs. We usually can guide you to the right vendor, or it has to, in order for Medicare to pay for things, it has to go through the doctor, and then we can help get it from there. So once a resident gets a power wheelchair, I feel like the power wheelchair police. And if someone here has one, Mark, and I kind of share the duties of supervision. So if any of you are concerned, and that's what I tell the residents at the other Oakville building, is we're a community, so we're watching out for the other residents. And so sometimes I have to do some teaching or some limitations on how a resident is using their wheelchair if they're at risk for themselves or others. So I think that's something I really, and today I was working with a resident, I consider power mobility, whether it's the scooters or the power wheelchairs, as a real privilege to have, just like driving your cars. And so I don't take it lightly that people can just go out and get one and drive it all over and have the speed. There's ways to adapt the wheelchair so they don't go as fast. People have better control. So we want to, because we're in a confined environment to some extent, there's still risks for injury if they're not used appropriately. So, all right. Any questions for occupational therapy?
It does sound like you have to have a doctor's referral first, is that correct?
Yeah. Yep. And that's for insurance purposes, of course. So when we, like the three things that I had a student today, I was telling her the things that we have to justify to Medicare are, one, is it medically necessary? And sometimes we have to do a little bit of talking people, or, you know, stretching. How can a broken finger, or I don't know, that's not a good example, but medically necessary can be the range of your quality of life. So medically necessary, the skills have to be delivered by a medical professional. Do you have those three things? No, okay. So like a nurse couldn't do this type of treatment, or a chiropractor couldn't do that kind of thing. So it takes the skills of a therapist. And then that there's progress, there's potential for progress. So there may be a point in your therapy where you've hit a plateau, and we decide together that that's about as far as you can come with that. Maybe your problems haven't resolved, but you have reached a level that you're comfortable with, that kind of thing. So therapy doesn't go on forever, and you guys understand that. So, yes. Oh, you give up on the mic, okay. Thank you. And that sounds like that $12,000 blood, yeah. Yeah, but that's good to know. And what we're really fortunate at Oak Knoll is that we've had a number of donations from residents. When they no longer need something, they'll donate it. And so we have an opportunity to trial someone in a power wheelchair that was donated. And so it's right there, and they can try it out to see whether they like it or not. You know, you can't test generally from a vendor. Once you drive it off the lot, it's yours. Yeah, it's not like a used car. So I think that's a real, walker, lots of different walkers, that stand-up walker Diane was talking about too. We have lots of equipment that we've been blessed with as donations, so. Yes.
Does Medicare argue with you very much?
Does Medicare argue with us very much? I would say only if we set ourselves up to be argued with. If we, I think it's important for us to maintain a standard of following those three things. We aren't in the business of extending therapy indefinitely, doing modalities just to make someone feel good. We have that accountability ourselves, and so we respect that Medicare has limits, and so we can respect that. It's pretty rare that we have what's called an audit or a denial, and so and in my experience, if you don't do anything wrong, they won't bother you. So the more that facilities abuse a situation, the more they become more susceptible to audits, I think. So.
And I was going to say, is it because they have tested you and found you responsible? And the fact that it comes from Oaknall or from you guys at Millennium, does that give you a certain power?
Or just that good?
Yeah, right.
No, probably not. I think
they
it's
do
more.
random. I think they do random audits, but
Yeah, I'll let you finish the answer to that.
I don't know exactly how the insurance decides, but I think that they generally do some random audits where they just kind of randomly pull charts and look at them. And like Karen said, I think it's probably more likely that if they pull something that you've done and they don't like it, they may pull another one that you've done to look at it and then see if there's a pattern. I think then you maybe become a little bit more likely to be audited. But as far as I know, I think they just kind of randomly pull things. But so that's why if you work with us, you'll see us diligently documenting, so we can try to document what we're doing, why we're doing it, to justify working with you. So
I don't know if Medicare really cares where the therapy's delivered from. Like we'd like to say Oaknall name has a reputation, and we do, but I don't think that is necessarily a link to whether Oaknall goes in this pile, such and such goes in that pile, kind of thing. So I don't think they sort that out.
And kind of related to your question, with Medicare, there is a therapy cap and a therapy threshold per year. Like that runs from January 1st to December 31st. And I think the therapy cap is $1,900 and the therapy threshold is $3,000. So once you have gotten to the level of like $1,900 with therapy for the year, then you may be a little bit more likely to have your file pulled because you use so much therapy. And then once you get to that $3,000 limit, my understanding is it's pretty certain your chart's going to get pulled and looked at before they agree to pay for it or deny it. But and they will. They have gone over. Let us go over if there's good reason for it. But I would say generally we don't get to the $3,000 per year limit. I mean, occasionally, maybe somebody has progressive diseases sometimes can contribute to you needing to have therapy more, or if you have, you fall and you break your hip in January, and then you have a knee joint replacement in June, and then maybe you get sick and go to the hospital, or have something else later in the year, then you might get to that limit, but I would say that's the exception versus the rule in general. We don't have too many people that hit the threshold for sure. So, but just FYI, Medicare does have some therapy limits. But,
We're going to talk about people that have 20 visits.
yeah, I can do that too. So they're also, so going along with that, as far as insurance limitations, pretty popular at Oaknall is Medicare primary, Blue Cross Blue Shield secondary policy. And that secondary policy does have a 20 visit limit per calendar year also for the Blue Cross Blue Shield. How that works is they allow you up front up to 20 visits with therapy per year, and that's usually per discipline, so 20 PT, 20 OT. If you get to that 20 visit limit, then there's a form online that we're able to fill out to say why we need more visits authorized. So, and we both know how to do that and have done it. I've done it hundreds of times, I feel like. And usually they'll authorize more. It still doesn't guarantee coverage, but it does authorize you to go ahead and treat, and that it likely will be covered, because there's never a sure thing from insurance, is what they always say. They can't ever guarantee that everything will be covered, but generally it is.
That's
So,
not right.
yeah. Yeah, so typically if you have Medicare primary, it covers 80% of therapy, and then it depends on what you have for a secondary or a supplemental policy. Like Medicare and a Blue Cross supplement policy pretty much picks up everything. The Blue Cross Blue Shield secondary, from my understanding from people that I've seen in the past that come back to me when I've asked them, they say they don't end up with any sort of co-insurance or whatnot, but there are some different limitations like that. Now, we have also had a few people from the university recently who have changed to like a Medicare Advantage plan, and the policy is escaping me. Can you remember what policy that is? I've had like 3 or 4 people in the last year that have switched to one of the Advantage plans, and we're not in network. So you don't have any coverage, basically, if you come to see us. So you can go elsewhere, like you go to the university, or I'm not sure what other clinics in town have that, are in network with that, but we're not. I mean, we can still see you, but it wouldn't be covered. So we try to make sure that you know that up front, so you can choose to look elsewhere. So with that being said, talking about the insurance, I'm going to go into how you come see us. So the steps to getting therapy services are to talk to your doctor, first and foremost, because like Karen said, we do require an order. It helps with insurance coverage, typically. So talk to your doctor about getting an order. You can also ask the apartment nurse, which I think over here is Kristen. If you don't feel comfortable calling your doctor to ask or whatnot, she can help facilitate that too. Your doctor may want you to come to the office to write the order. Some doctors are comfortable just, if you tell them, you know, my knee's really hurting and I'd like to try therapy, they'll just write the order and send it. So, or they can give the order to the nurse too. But we do have a fax machine in our office that comes right directly to us. Nobody else gets the faxes, it's just us. So if you ever do need therapy and want your doctor to just send it right directly to us, we have a fax. And I can give you the number. I don't know if anybody has pens if they want to write it down, but
Kristen would have that.
yeah,
maybe.
yeah, we can make sure Kristen has the number too, so that if you need it, you can talk to her and she can give you the number. That might be easier. So, but we do need to have the order before we see you. Then once you get the order, or we get the order, if you get it, you just need to call and let us know. And I don't know if anybody here knows, can you just dial the extension from here to get to the other building? Okay. So we have an extension 3860. It should be in, if you have a phone list, it should be in there. You can just call us and let us know that you have an order. And then once we hear that from you, we'll request from Lisa Chapman in the business office to do what we call an insurance verification. So what she'll do is she'll take your insurance information and she'll go through the system to look at it. Number one, to see if you're in network. And then to kind of find out how much, if you've had therapy in the past, how much of your money you've used already, if there's a deductible, a copay, co-insurance, that sort of thing. So always make sure if you have an insurance change, I would encourage you to make sure that you give that information to Lisa Chapman. Or if you're going to be having therapy, make sure you get that information to her right away, because that's the other thing that we need before we can work with you is the insurance verification. Because like I said, if you're out of network, the last thing I want to do is start seeing you and then find out that you're out of network and you're stuck with the whole bill when you could try somewhere else. So we need to have the order and the insurance back, and then once we have those things, then we'll contact you to get you scheduled to see us. So, and then our preference is that if you're able, we would like for you to come to us at the main campus, just because we do have access to more equipment. Our ultrasound, stim, that sort of stuff is not really very portable. But if you can't get to us and you need us to come over here, we can do that. So you just have to let us know what your needs are. Our office over in the main building is located on the first floor, kind of off the short stay unit area. I don't know how familiar everybody is with the other building, but down on the first floor, short stay, we have a little, well, pretty good sized gym area in there to work with people, so.
Is that by the health center?
Yeah, so the health center, you come in off that side entrance, and that's the second floor of the health center, and then we're down one level from there, so yeah. And Oaknell does submit everything once we put in our charges, and then they submit it through your insurance. It goes through your primary insurance and then your secondary insurance, and then if there's anything left over, if you have a co-insurance or a co-pay or whatnot, then my understanding is that comes out on your Oaknell bill once everything's gone through. And that whole process can take a while for it to get through all your insurance before it comes out, but so that's kind of how that part works. Are there any questions on how to get an order or insurance?
One of the things that I wanted to talk about is skilled therapy on the short stay unit. So that is on the same level as our therapy gym. So if someone were to have some kind of surgery, it doesn't have to be orthopedic. It can be stomach surgery or some kind of thing where you don't feel, you've been in the hospital, I think it's back to qualifying 3 overnight stays. You will qualify for more intensive therapy, and that has to be done in the short stay or the skills unit at the main building. So that is covered by Medicare A, which is different than the outpatient Medicare B. And that unit has about 12 rooms, more than 10 rooms. Therapy is 5 days a week, 45 minutes to an hour a day. So, and the range of stay for most folks, it varies 2 weeks to, a couple months. I don't want you guys to be afraid of coming over to the short stay. If you have an issue, it's really a great way to jumpstart your rehab, and then before you return home. So all the therapy is covered. It's a high ratio of nursing to patients there. Our goal is to, with the short stay or the skilled unit, is to get you back to where you were living before. It's not a direct admission to the health center or anything like that. So, yeah, your question.
Is it a given that if you have 3 or more nights in the hospital, you'll end up at the short stay, or is it just if you need it?
The question is whether it's a given that if you're overnight 3 nights in the hospital that you automatically are admitted. My understanding is it's totally patient-driven, or it's totally patient choice. The social worker or case manager at the hospital may present that as an option, and we have had beds available most of the time, really, and and when you come, we do encourage three days, or at least 3 days of therapy before you return home. So it's not like I'm just going to go there and stay overnight until I feel better and then go home. So we'd really like to, it's worth the paperwork to have you stay 3 days, but also Medicare doesn't really like to pay for all that, all that nursing admission and all that for just 1 to 2 days. But I would say average is 2 to 6 weeks. Would you say?
Yeah, I spent a month there last fall. Wonderful care, very nice.
I'd like to repeat that report.
You should take him the microphone.
Yeah, Mark says he spent a month there and had a good experience. So, and I think it's, and most nursing homes anymore have skilled care. So they would offer you your choice, and you could really go, you know, any place. And a lot of the facilities, Oak Knoll is the only facility that our company is contracted with in Iowa City. Cedar Rapids, there's probably 8-10 different nursing home rehab centers that we serve. And Solon is the other close one. If you have family in another area and want to go to skilled care, that's an option too for many people. So I think there are advances happening all the time with joint surgeries that you might very well be comfortable going home, but I feel like we have some things to offer to help with your transition, so you don't get so frustrated at home too. So, any questions about skilled care or at short stay? Okay.
Equipment, I was gonna kind of touched on that as far as that we don't sell equipment.
Yeah, go ahead.
One other thing I was kind of thinking about while we were talking is Karen touched on equipment a little bit and some of the different things we can try. You know, we have donated equipment that we can try with you, but we don't actually sell. Like I can't sell you a walker. You would have to go get that from a medical supplier in town, or, you know, the different drugstores or Walmart. Those different places do have walkers options, but as far as getting them, we don't actually sell them. So that's a question we get a lot, is people want to buy them from us, and we don't have equipment to sell. Just, we have it to try with you, so you kind of know what you're looking for.
But so that supply of equipment that you have is not for you to loan out either?
We'll loan it out. We usually say 30 days.
Okay.
And then if you need it longer, we'd like for you to get it so that we have it available if we need to loan it to somebody else, basically. So, you know, sometimes we'll have people that have a knee joint replacement and they'll come to us, and we know they're not going to need it long term, so they'll borrow it, and usually within a month they're done with it anyway. But or, you know, whatever the reason is that you've come to the short stay and seen us, or if you've gone home and seen us, if we feel like maybe there's a chance you could get away from it, we'll just have you borrow it, like I said, for like that 30 days or so, because then by then we'll know whether we think you're going to work away from it or not. Even if we're not seeing you, you can borrow equipment from us, but again, we try to keep it to 30 days because we have a limited supply, and if everybody wanted to borrow, then we would run out and not be able to let other people try it out and see. So that's kind of our policy for that. But
The exception is like a shower chair, a toilet riser, grab bars. We are able to order it through Oak Knoll and put that charge on your bill if you don't want to order it yourself. So something like that would be, you would purchase, we can help you with that part of it. So those are a little lower cost item and
not covered by insurance.
and aren't covered by insurance, right?
Yeah. So with the walkers are something, and sometimes canes or wheelchairs depending on necessity, but for me, most of what I see is walkers that sometimes will be covered by insurance. So if you need a walker and you haven't had one purchased by your insurance company before, you can get insurance to help pay for a portion of your cost for your walker or cane or whatnot, based on necessity. And in that case, there's a steps that you have to go through, getting an order from your doctor, and then that order you have to take to a specific place, like a qualified medical vendor, which would be like CarePro, Community Medical, New Car Pharmacy, those kinds of places that specialize in medical equipment, and they're able to bill Medicare or bill your insurance for you. So walkers, like I said, are the things that I most often see that get covered. Most of the time people don't submit canes because they're usually around $20, and so a lot of times people will just buy them, but they will go up but not down, right? Like if you have a walker, they wouldn't buy you a cane, right?
Right.
I can't remember.
Right.
So there's a limit too on if Medicare purchases some equipment for you, that if you were going to get another walker, you'd have to wait like 7 years, 5 years?
5 years, I think.
5 years, 5 or 7 years. I don't sell the equipment, so I'm not exactly sure on the specifics, but I know enough to be dangerous. There is a length of time that you have to wait before you can get them to pay for more equipment for you. But most of the things like Karen was talking about, the tub benches, grab bars, things like that are not covered by insurance. So those things, sometimes we're able to order in. And we can order you a walker if you don't want to put it through insurance. You can go through a catalog and order one, but most of the time people prefer to go. And there's so many different styles of walkers out there. It's kind of like a car lot. You want to go, there's colors, there's styles, that people have different things they're looking for. So I usually just suggest you go to the store and kind of look at it and see if it's what you want. So based on, we give you some general guidance and then you can look for the aesthetics. But, any other questions on anything for us? Yeah.
This is probably a silly question, but the phrase "going to rehab," what does that mean? I mean, is that the skilled care? Is that the short stay? What is that?
Well, in Iowa City, we have two new, what's considered acute rehab. There's one through Mercy and one through the university. And that is, acute rehab is a minimum of 3 hours a day of therapy. It's generally from a pretty extensive change in a pretty extensive medical condition. I think, and that's determined by the hospital. They go directly from the hospital to them. So that, and they'll qualify, as long as the patient tolerates that 3 hours of therapy, that's intensive rehab, I would say. Skilled therapy, and that's covered by Part A too, I think. And then the next level of care would be skilled care. And people consider us rehab, you know, because you're getting therapy 5 days a week. And then probably the next level of care would be the Part B, or, you know, a few days a week, or as an outpatient therapy. So I don't know if that answers your question. It's not, because it's a category we're kind of throwing around, a term that's thrown around. So yeah. Yes.
So what's different about Mark's wheelchair? You know, you said that you had to learn from his, and he mentioned, you know, and you've mentioned too, the ability to go up and down and tilt and backwards and forward and all that stuff. Why is his different than what you're used to, for instance?
Let's see. HIPAA violation would be.
Oh, well, I'm sorry.
I would say in general, if a patient orders their own wheelchair, it takes me a little bit to determine or to learn it. And some individuals will order. They'll see an ad in a catalog and order that wheelchair, and I'm happy to help them through that. But there may have been some things that I could look at and determine that's not appropriate for that individual. So before a big purchase like that is made, I really encourage residents, same with walkers. People go out and buy a certain kind of walker that's not really meeting their needs. And so then, and I think that, you know, it's like anything, with the internet being available, you can search and find whatever you want, and this is the cheapest one, I'm gonna go with that, which, you know, may or may not be the best route. Does that, yeah, so I can't say too much about this, but.
I just didn't know what all wheelchairs could do these days.
Yeah, and that's what I was gonna say. So in general, there's a lot of different features that wheelchairs have. So you have different types of like footrests or foot pedals. So some of them are just static and they are right here and you can't move them. Some of them you can swing them away. Some of them you can take them off. Some of them don't swing away at all. They'll fold up underneath. Some of them, the armrests are fixed and you can't move them. Some of them you can take them completely out or you can flip them back. Some of them have a high back, so there's a lot of different features that you can get on a wheelchair. We've kind of used the car analogy several times today, so it's kind of like a car. You know, you can get different features on a car, and it may or may not be what you need. So there's just a lot of different factors to consider based on your mobility, based on what you want to do, how heavy it is. Mark referenced that he had a chair that was big and heavy, and it would raise me to the ceiling, but it was super heavy. And if you want to be able to travel, then you have to have a special kind of vehicle to take that in, whereas there's lighter weight ones. So there's kind of a lot of different things that you don't even think about. And Karen's usually pretty good at kind of looking at all of those things, because even I don't think about some of those things sometimes, since she works on them. Things that may be helpful. So you may need to, depending on how the footrests are in the front, can you get off the front of the wheelchair, can you get off the side, where do you need to be able to get out of the chair, how big is the chair? Some chairs are really long, some chairs are narrow and will turn on a dime, so there's a lot of different potential features on a chair to take into consideration. So that's...
Are there attempts these days to develop wheelchairs that can go up, you know, up a step or
Do you know the answer to that? I don't
like that?
In my,
It's just a matter of
yes.
curiosity. It's not really.
When I worked in the schools, there was something called a stair climber, and the wheelchair would pull up into this, and then I think it was like almost like a bulldozer, like the tread, yeah. And so you'd lock the wheelchair in, and then in these old school buildings, you know, weren't accessible, and so that was kind of one option. I haven't seen a lot yet. There are wheelchairs that will move you from a sitting position. You push a button, and it stands you up, so you can get weight bearing on your legs, you know, things like that. So.
Well, yeah, and I guess with ADA, it's more modifying the surroundings than it is working on the technology too.
Right, and that's where that came from. Yeah, absolutely. Yep.
Thank you.
Yeah. Good. All right, well, it's been a pleasure getting to share the afternoon with you, and we're happy to answer any questions. Our extension's 3860, or call the operator and she'll help hook you up. So you're all looking in good shape now. I don't see any potential clients at this point, but we're here if you need us. So, all right.
Thank you.
Thank you. Okay.